Dear colleagues, welcome back on this Sunday US and ESB webinar. This time we have once again a very interesting topic. It's a futuristic topic. I understand that currently in Pakistan, we are not doing this procedure and we don't see much application considering the cost, but definitely when it comes down to the saving the life and giving comfort to the patient, even now there will be certain patients who will be benefiting on the cost effective basis as well. Uh, to speak on this topic, we have none other but Dr. Sandeep Lakhtakia, who is an expert in this procedure. He has shown his skills to the world, and he is respected for his EOS-guided skills in all the interventional procedures, not just the EOS-guided gastrostomy. He is one of those people who has done maximum numbers of EOS-guided gastrostomy. We were just talking about the cost effectiveness of this procedure and applicability in the economies like us, and he's going to highlight in detail on this particular topic. Sandeep, all yours. Thank you very much. This is your, I understand this is your holiday. It's a special day and you spared your time for Pakistan population, and we are thankful to you.
Thank you, Professor Gyas, for such kind words. And it's a pleasure and honor to be here amongst all of you on this day. I think academics makes us more lively than the festivals. And that's why when my friend Saad called me up that, can you do that? 3 days ago, I said, okay, why not? So the topic that we have today, as you see on the screen, is on this EOS and ERCP weekly webinar in Pakistan, which is very famous, I'm told by Professor Gyas, and I'm glad that I'm amongst all of you. So this is a topic of EOS gastrojejunectomy, EOS guided. This is a very recent procedure. I think just about the first description came about in 2016 and as a novel procedure, and several experts in EOS tried their hands on it in different ways. There is no best way as yet, but we can discuss as we go forward in this talk. And why is it useful also we can discuss moving forward, if I can. So EOS guided gastrojejunectomy, I think this term may be a little not correct or inaccurate, and that's why, oh, what's happened here? EOS guided gastrojejunectomy instead, the correct term is gastroenterostomy, because from stomach we could be or it could be jejunum. So one of the small bowel parts would be connected, and sometimes we're not sure when we're doing it which part we have actually anastomosed by EOS, and hence we use a broader term of enterostomy. So in this talk, I would like to cover what is EOS gastroenterostomy or GE, how is it done, is it safe, and how is it compared with other modality of gastroenterostomy, that is surgical GJ. So if you see the picture here, although this cartoon doesn't look very nice, but see it very carefully, this is the stricture here in the duodenum. So anything which is causing gastric outlet obstruction, benign or malignant, often requires surgery. For benign, we can consider duodenal balloon dilatation for a peptic ulcer related disease, and it works reasonably well. But for malignant disease, the options are either we place an enteral stent or do a gastrojejunectomy surgically in patients who are fit enough. But often these patients may have advanced disease and surgeons are reluctant to do it. And that's why the procedure of gastroenterostomy or gastrojejunectomy has been evolved. And this is how the stent looks like when it is placed accurately between the stomach and near the DJ flexion. It can be third, fourth, or beyond DJ flexion. The surgical gastrojejunectomy is generally a much bigger anastomosis compared to what we do by EOS GJ. The current stents, the widest available is Axios, which is 20 millimeter. Spaxis is about 16 millimeter, and which is much thinner in diameter compared to what surgeons do, which can vary from 2 to 5 centimeters. So how does it differ? If you see the screen here on the left panel is surgical GJ. It gives a durable relief of symptoms. There are very fewer re-interventions because of surgical GJ going wrong. although there can be some risk of procedure-related events, which is very rare in expert hands. And hospital stay compared to EUS GJ can be a little longer, but it's nonetheless in the, if cost is a constraint and surgical GJ is possible, I think surgical GJ should still be done. But if the demand occurs for gastrojejunectomy or enterostomy, then we use lamps, which I'll discuss later. It's an endoscopic procedure, has a long-lasting effect, generally sustains or outlives the patient. Although it's very early experience, and this is growing up as the experience of EUS interventions going up. The stent that is used sometimes can get mal-deployed because of a variety of reasons, which I can discuss later in my talk. So coming to the most interesting part of this thing is, how do you do gastroenterostomy? To show in a cartoon form, I used a slide from this article, which is a very nice article. People can just note it down, by my friend Takao Itoi and his colleagues, who have published in Clinical Endoscopy, which came last year in December. And there are several ways of skinning the cat that is doing DJ. The first one is you puncture with EUS, the jejunal loop, which is closest to the stomach, which you often see when we do routine EUS with a linear scope, and then pass a guide wire, and over that guide wire you can place a stent. Looks very straightforward. But mind you, jejunum is a very loose structure, except for the DJ flexion, which is fixed. The rest of things are quite loose and can be floating around, and your stent can get pushed away. Or your accessories can actually push away the bowel, and stent can get deployed in the peritoneum. And that's the gravest risk. If you do that, then often the patient ends up with surgery if it's a mal-deployment. I will discuss that later. And there are several other ways of doing it. So this is a freehand technique by which you fill up the jejunum and pass guide wire and then put the stent. Other methods which have been described is put a balloon using an endoscope. You pass a guide wire across the stricture deep down into beyond the DJ flexure, and pass a CRE balloon, which is then inflated with the contrast, which is seen now well from the stomach. And then you puncture it, the guide wire coils inside, and then you pull back the entire assembly with the guide wire along with it. And that will help you in anchoring you can now have the wire held from both the ends, and then you can push it across. Techniques were described when the hot axios was not available or the cold axios was there. The technique which I like most and the safest, I believe, is the one which has a special double balloon. This is again designed by Takao Itoi, my friend from Japan, and this is a balloon which has a capacity of about 40 cc, and the two balloons are about 20 centimeters from each other. This is passed over a guide wire on the special kind of nasojejunal tube with the balloon within part of it, and this is taken beyond the DJ flexion, much beyond the obstruction. And once this is inflated, then the intervening segment is filled with a saline, contrast, and a coloring agent. And this becomes like a fixed pseudocyst. And we are now kind of quite comfortable draining a pseudocyst from the stomach. And hence we can use a hot axios to make a bridge between the stomach and the distended jejunal limb. Few other methods which have been described is again passing a needle into the distended jejunum, pass a guide wire, which is then now caught and pulled back this way, and then you can actually do another way of placing the stent from the enteral route. So there are several ways. Let's touch one by one. So this is the freehand technique by which, as you can see in this cartoon, the stricture is here. You fill, just using a same EUS scope, fill the distal part with a lot of water, saline, coloring agent, and contrast. The advantage of contrast that you can see it on the fluoroscopy, and the coloring agent is meant, which is either methylene blue or indigo carmine, so that once you have successfully placed a stent between the stomach and the jejunum or the duodenum, then that coloring agent immediately comes in the gastric lumen. You can see endoscopically, and showing that you have placed the distal flange in the right place. So you fill this area, which you see nicely on EUS. Then you can, one method is to puncture with a needle and aspirate to reconfirm the final before you place the stent. And once you have placed an axios, you can actually dilate at the same time. Although most people now don't prefer to dilate because of risk of stent getting dislodged, and let the stent expand on its own in 2-3 days time. But this is one of the ways which has been described. So let me show you a couple of videos of how this freehand EOS guided gastroenterostomy is done. So you use a regular upper GI scope or the same EOS scope, get these loops which are very close to it filled up. So the technique over here also is a small trick that you use an anti-peristaltic agent. In India, and I'm sure in Pakistan also used hyoscine, that is Buscopan, quite frequently, so that the bowel which is distended doesn't let the fluid go distally. Because as we keep filling, the distal loops keep getting filled up, and sometimes if the procedure takes longer time, we may not be sure which loop is close to us and which is far away. And accidentally, some people have done actually gastrocolostomy. So this is the needle being punctured, and then you pass the guide wire uh, and then place the stent. Guide wire is not considered now as a preferred method, because once we puncture and put a guide wire, that guide wire pushes away the loop. And since it's a freehand technique and there's no way of anchoring, it may be a good idea to just use a freehand technique. And you have, after identifying the loop which is closest to the stomach. Then there are other methods of EOS gastroenterostomy which use an assistance instead of freehand. And these accessory devices which are used for small bowel distension, which are filled with saline before puncture and stent placement, can be in the form of a balloon, which can be a stone retrieval balloon or a CRE balloon, or a basket which is placed on a stone retrieval balloon, or sometimes just a nasobiliary or nasojejunal tube. So the tube not only fills the distal loop, but also helps you identify that this is a loop which is closest to us. So let me show you an example here. These are the videos which are provided by my friend Shahin Irani. And if you see the video here, this is a stricture. The regular endoscopy is used. The guide wire is passed deep distally. And now I can see in the video. So once the stricture is identified, guide wire goes quite deep as possible. And over this guide wire, you pass a balloon, which can sometimes use another device to anchor it, or it can go beside it also. So there are two ways of doing it. You can have guide wire, which is over the guide where you pass the balloon, or you place it beside the guide wire, which is working. That's why you use a foreign body forceps to push your balloon inside. And once the balloon is inflated, you can see it accurately and puncture with a needle and then pass a guide wire below. So now you have two ways of reaching that. One through the transgastric route, the guide wire is, and one is transpyloric, the guide wire is reached, just in case if there is a mishap. And then dilate this path with a balloon and then place a cold axios stent. This was the earlier methods when hot axios was not available. Even the initial hot axios were also used in a similar manner till the people got comfortable with hot axios. Moving forward, there's another method of roundabout balloon trap method. As the name suggests, you actually use a similar mechanism of passing a balloon inside. This is a CRE balloon, inflated with contrast, punctured with now a needle. And then the balloon, the collapsed balloon with the wire inside, it is pulled back while we are pushing the wire in through the EOS scope. And this wire is now coming out of the pylorus into the stomach. So you can now put either from the stomach into the jejunal side. Another way of using a balloon is a stone retrieval balloon with a basket on top of it, so that the wire is grabbed well and you don't lose it. So nevertheless, the principle is that you get the guide wire out of the pylorus into the back into the stomach and back into the mouth, so that now you have a traction available, and then you can place the stent and it kind of fixes the jejunal loop close to us. An extreme way of doing EUSGJ is called as retrograde Eu Gastrostomy. Here a regular endoscope is being passed now beyond the stricture, which looks a little peculiar because you have a stricture and a scope can go beyond. Then same principle is applied. You pass a balloon and then once you have anchored it well, in this way, in this method of jejunal you place from the jejunum into the stomach. So this is how it looks like. So the distal flange comes out of the stomach. You place a scope beside the EUS scope, as you see it here. Now the two wires are there. This is one which is punctured out from the stomach into the jejunum. But the deployment starts from the jejunal end. You see from the jejunal, you start deploying these stents. Here goes the stent, which will come out of the stomach, which is actually catching the nose from not from front, but going all the way around and catching it from behind. So it looks a little peculiar way, but nevertheless, this has been described too. And a second scope is passed to see the gastric end. But the technique which I said earlier, which I believe is the safest, is EUS guided double balloon occluded gastroenterostomy. And this is how the picture looks like. The two balloons are kept about 15 to 20 centimeter. Currently, the balloon which is available is about 20 centimeter gap between the two limbs, and intervening area is filled with about 150 to 180 cc of saline contrast and a coloring agent, which then distends it well. And then you can place the stent. And after a few days, if you do an oral contrast study, the contrast goes distally, which is what we want to do. And the stent which has made all the difference is this lumen opposing stent, the Axial Stent. It's a dumbbell shaped stent which is 1 centimeter long and diameter of 15 or 20, which has been used for GJ. It is made of beaded nitinol. It's fully covered and hence prevents any leak. It has wide anti-migratory flanges which cause a lumen apposition and doesn't allow the stent to migrate on either side. The current hot Axios has made the job much easier as a freehand technique once you distend the lumen well by whichever way. For the beginners, I just want to show this cartoon video of how the Axios, hot Axios works, this cautery enhanced delivery system. It has 4 steps marked on it, and you have to go one by one in sequential manner. First, burn your way in from the stomach into the target organ, which is jejunum here. And once you are comfortable, then you pull back and deploy the distal flange, pull back and abut the inner wall of the target organ, and then see this black mark here to deploy the gastric end of the Axial Stent. So it is quite a user-friendly device once you get accustomed to it. But for the beginners, sometimes it is not very intuitive because we've been using stents, the tubular stents for biliary and the esophageal or the enteral stents, which have a different delivery mechanism. And this delivery mechanism, although it has supposed to be prevents any complication, but in the beginning we need to learn which the button should be locked first and which should be left open, because one of the distal part controls the sheath and the proximal part controls the stent, and that understanding has to be there when we move forward. So just show an example of how this works in a real life scenario. This is a patient who had duodenal obstruction and obstructive jaundice because of periampullary carcinoma. So he had first a biliary stent. Few months later, he came with outlet obstructions and enteral stent was placed. The patient outlived both the stents, especially the enteral stent, and he came with outlet obstruction. So we passed a guide wire. This was the first GJ that we did almost more than 2 years ago. So first pass a guide wire and then pass a nasobiliary tube into the jejunum to be more comfortable. And then we use an E-pass balloon method. For E-pass, we always use an over tube because it's a very floppy nasojejunal tube. And if you use it just directly over the guide wire, it'll coil in the stomach and it doesn't go beyond. So the overtube helps us, the long overtube, which is available with the current small ball enteroscopy, the single balloon enteroscopy, is the same overtube. So this is brought to the pylorus almost into the first part of duodenum, so that, and it fixes it there. And then the whole balloon can go through it and doesn't now coil in the stomach. And once you are beyond, the balloon is then passed over the guide wire, which is passed as deep as possible. And you inflate either both the balloons simultaneously or one by one. So distally has to be inflated first with contrast, which should be about 30 to 40 cc. And then you inflate the proximal balloon. And now the intervening segment is now fixed. There is, in whatever we fill will not go either distally or come up proximally. So here we are filling the contrast with some coloring agent. Contrast so that see under the X-ray carefully. The patient should be kept in supine or a prone position. I'm sorry I did not say in the beginning, but I think that's important so that your anatomical contours are now well defined. And once this is filled, while we're filling, then you pass the EOscope inside so that we can see the filling in real time, as we'll see it now. One more thing that we look at is the jejunal tube, which will be seen soon. This is a jejunal tube, limbs getting filled up, and the tube also can be seen. Like little bit of ascites is not a contraindication. If person has too much of ascites, you can actually aspirate as much as possible. So you see, this is the limb here. I'll freeze it here. This is the jejunal tube. The reason I am pointing it is that some times we use a freehand technique using a nasojejunal or nasocystic tube. This also is a guide to tell us that this is where we have to be, because this will only go to just beyond DJ flexure of maybe a 10 or 20 centimeter or maybe 30 centimeters. But if you keep filling and the procedure time is long, then sometimes the contrast keeps going distally, and you then fail to realize which is the loop which is closest to us, because the small bowel, which is about 15 meters long, can be, so you can end up doing gastroenterostomy towards the ileum side, or even colostomy has been described. So we don't want a gastrocolostomy to happen. And that's why I look at this as an additional surrogate marker of where we need to go. In one of our recent workshop examples, this tube actually, looking at this tube helped us. So now you have a good limb of a jejunum close by to the stomach, and that's how it looks like on fluoroscopy. So keep a fluoro view, and once you see the good limb distended, then you fire with your axios, and rest of the procedure is as easy or as comfortable as you are with Axial Stent. So distal flange is seen first. You pull back as we do in pseudocyst drainage so that it anchors well, gets a little deformed, the inner flange, and then you see the black mark and deploy under endoscopic vision, or sometimes we can deploy in the channel of the scope. So this blue coloring agent helps us here that we are in the right position. And that's when your heart rate actually normalizes. So this was a position of the stent between the stomach end, and this is the DJ flexure end. And a few days later, when we did an oral contrast study, we can actually see the contrast going down, which is what we wanted. So the technical success currently reported of EUS gastroenterostomy is about 93 to 100%. Obviously, as we do more and more, this success keeps increasing. And clinical success, that means patient having no outlet obstruction symptoms and vomiting subsides, is also quite good. So I always say this is a very high risk, high reward procedure. So if everything goes well, you get rewarded. But if it goes mishap occurs, then there are several people laughing around you, and the patient can sometimes go to surgery as well. How to avoid surgery, we can discuss as we move forward in this talk. Let me show some other examples of gastroenterostomy. This is afferent loop syndrome. This is a patient about 4-5 years ago. A patient who had a benign cause of afferent loop syndrome. He had a peptic ulcer disease for which about 15 years ago he underwent a distal gastrectomy and a gastrojejunectomy. And this is afferent loop, which is quite distended. And he presented with pancreatitis and obstructive jaundice. See, the PD is dilated here, and so is the bile duct. And he was quite sick. An ideal thing would have been surgery, being his benign disease, but he had cardiac issue with atrial fibrillation, and surgeons were reluctant. So we thought we can help them out. So you can see the dilated afferent loop. We published this in, I think, Endoscopy some years ago. And through the GJ, when we enter, we could actually go into the efferent limb, but not the afferent limb. And this is how the EUS looks like, a very hugely distended afferent lobe, almost like a pseudocyst. Lo and behold, we can now do it like a pseudocyst drainage. So we punctured with a needle, passed some contrast after the guide wire, and then use an Axial Stent after dilating the path with a balloon. This is a cold Axial. So it has also a lumen opposing capability, and this has a design by which the inner flange looks like the frog's leg actually, the frog from the dorsum if you look like that. And the gastric end is then being deployed. This stent also expands on its own. This was a 16 millimeter. So check endoscopy 2 days later showed that we can pass an endoscope inside and go to the afferent limb, and his symptoms actually improved. So we reported about few months after this procedure, they can see the aerobilia, the air has actually gone inside the bile duct just by placing this stent. Not only that, we then removed this stent because this is a benign disease. I didn't want to leave this stent for long. For about, I think 9 months later after the stent placement, we removed this stent. And the patient is currently on follow-up after 4 years of index procedure of placement, and is doing fine. That means that opening is working well. So that's a good saving grace. Let me show another example of afferent loop syndrome. This is a patient who had a malignant gastric outer obstruction, CS stomach, operated about 6 months ago, and he had a distal gastrectomy. So in this patient, I'm sorry, I don't have the EOS image, but we were not able to clearly define the afferent limb. The stomach was full of food residue, and the stoma had tumor presence because of reoccurrence. But his main symptom was because of afferent. He was having pain and vomiting and some pancreatitis. So in this, we punctured this so-called suspected afferent loop by a needle and injected contrast. And again, we've got the patient in supine position. We want to know that the loop has to go in a C, the C loop has to be filled up or identified. So when we punctured and then passed the guide wire, so clearly then we could define that we are on the right path. So if you have a doubt of in the right direction, you can use this method of a guiding a needle, which can tell you which way to move forward. This is a jejunal tube in the efferent limb of the GJ, which was used for the feeding purpose. So that was also helping us that we are not in the other path, because there's no point doing a gastroenterostomy in the efferent limb, which is actually functioning. And then we place an axial stent over the guide wire this time, because this is a fixed area and this won't move away, and there's no need of a double balloon. And we also place an anchoring stent just for in case it has a issue. And the stent expanded few days later, and patient symptoms got relieved. Another patient who had very recently we did as a of GJ is a patient of a CA stomach. Normally we don't do in patients who have a cancer in the stomach, and but this old man was operated about 6 months ago with a Roux-en-Y limb of gastrojejunectomy. And now he had come back with reoccurrence of cancer, and the stoma was totally blocked, and our guide wire and contrast did not go at all across the GJ. And because it was straight from stomach into the efferent limb. So what we did was we saw some loops next to the stomach and we injected contrast. And this is another way of finding which way to go. So we injected contrast and filled it up. And you can see the contrast going distally. Am I audible? Yes? Hello?
Yes, you're
Uh,
perfectly audible.
Okay,
Perfect.
okay, okay. I thought it was a
we all,
one-way communication.
no, we are all loving it.
Okay, Nadeem. Thank you, Nadeem. So as you see it here, the proximal limbs were not very dilated, distended, and all the contrast and distal, we were wanting to see something like this close to the stomach, but this was far away. And it was basically because of the tumor which was infiltrating this area. And then we kind of modified a technique. We passed the guide wire and then use a cystotome to create a fistula. And our initial thought of placing a 20 stent, we changed to 15 because not enough space was available. If we had placed a bigger stent in a smaller caliber lumen available, we could have also caused some mishap. So we now decided to place a 15 stent, and this is how it looked. And let me go back a little bit. The first picture. So here, if you see, this is actually a contrast which we injected in the bowel. It is a submucosal injection. So it caused a big bleb. We thought in the lumen, but it didn't fill up as well. And then we had to pull back the needle and re-inject again. So this was another thing which we observed. The submucosal injections can happen when the bowel is collapsed, as we do endoscopically to raise tumors. And a few days later, we did an oral contrast study, and some contrast was going across, but stent still has to expand a little bit more. But now it is at least in good position. If you see the previous image, it doesn't look very nice. The distal flange, I was a little concerned that whether this will slip out because this limb is very long. But that's a beauty of the lumen opposing stent, that they come back and both the flanges come to each other close by. So what's the difference between EOS GJ and surgical GJ? What does the literature say? There are not many studies out there. These are retrospective studies. This is an international multi-center comparative trial of endoscopic GJ versus surgical GJ. And in this retrospective study, they had about 93 odd patients, of which 30 had GJ and 63 had surgical GJ. But the conclusions which the authors gave in the end was that there's equal efficacy of EOS gastrojejunostomy or enterostomy, and it is equally safe with compared to GJ. That is, EOS gastroenterostomy is non-inferior but less invasive alternative to a surgery, which means that ideally surgery should be considered in all patients, but those who are unfit for surgery for a variety of reasons, it could be because of the stomach getting involved, or there is ascites, or the lymph node, or the surgeon is not willing to touch that patient because of some other reasons, then you can actually bail out these patients who can actually have in the last phase of life ability to take things by mouth and live comfortably. That's what all want. Expanding this further, gastroenterostomy has also been tried by EOS in benign gastric outlet obstruction. And there are several publications now, a small case series. As you see it here, this is a 26 patient series with Todd Banner as one of the author. And that shows that EOS gastroenterostomy is a promising treatment for benign gastric outlet obstruction. And how long does it work? So if it is placed in a benign condition, the median patency rate, which is described as 319 days, almost like an year or so. The range is almost to 2 years. And in malignant, they often outlive the patient, and the median described is 6 months plus. So why do we do all this? Why not do a common garden enteral stent, which I'm sure a lot of people would be thinking. This is a complicated procedure with high risk. Why not simple the enteral stent that we've been doing for years together, and the stents are fairly good. So looking at now at the GJ EOS guided versus enteral stent in palliation, this was a paper which came 2 years back in surgical endoscopy from Chris Thompson and his group. And they compared 100 consecutive patients, and they found that the stent failure by enteral stent requiring repeated interventions as my index of the first case which I showed in the beginning, that enteral stent was placed about 6 months ago and that got blocked. So sometimes patients who outlive their stents require something more, and placing another enteral stent to the previous enteral stent is not very good idea, I believe. So they had higher clinical success with gastroenterostomy EUS guided. There is more increase in adverse event with enteral stent. So net EUS guided gastroenterostomy has a higher clinical success and a lower rate of stent failure requiring any intervention in follow-up. So this was the summary or the conclusion of their paper. And that makes little sense because in enteral stent, we go through the malignant tumor, and often we use an uncovered stent because that has less chance of migration compared to a fully covered stent. And in a bargain, we get the tumor coming into the mesh of the stent and blocking it, which can come as early as in a few weeks' time to a few months later. So staying away from the tumor makes a lot of sense if you can do it in a very safe manner. So gastroenterostomy away from the tumor, that means doing a GJ near the DJ flexure, makes a lot of sense because the tumor in the pylorus, D1, D2 or D3 can all be taken care of by this procedure. So what are the issues with EUS guided gastroenterostomy? Sometimes we have these variations in DJ flexion, and some of you must have observed in the last live workshop that we did for ASGE on 5th of March this month. Our duodenum was something like this. The DJ flexure was somewhere here. Normally it should come like this, and that would make the job very easy. But in that case, the patient had and we were unaware of it prior. So our scope position, unfortunately, I don't have the video modified. It's a very long video which needs little time, and because of the sudden invitation, I had to just show what really happened. In this case, we have to go in a very long position to reach this area. So mind you, one has to be a little careful. So you can do a dry run if you're planning a GJ in a patient 1 or 2 days before, where you can put a nasojejunal tube for feeding purpose, which can also work like your a dry run where you can know the anatomy of the duodenum. Is it favorable or not? If it's unfavorable, it's better to ask your surgical colleague to do in the beginning of your career. And once you get experience, I think then you can try in different settings as well. Second thing which can happen is a tenting of the jejunum. We are puncturing from here, and sometimes if we are pushing too hard and not burning as much, the jejunal limb can actually go away, and you have not burned the wall of the jejunal limb. So a stent can get deployed in the free space having punctured the stomach. We have had experience of this in the beginning of a career, and this is a much easier complication to handle because you only punctured the stomach and the jejunum is still free. So what you can do is just pull out the stent. That goes waste because you cannot reconstrain the stent, but at least you can cover the gastric opening. And often the gastric opening quickly collapses. It's very difficult to make out where we've made the hole. So the way to look at it is using a cap in an endoscope by which you can tease open the folds, and then you can look at the opening, and you can use a clip or a Ovesco device to close that. But even if you don't do anything, sometimes these can often close on their own, but this patient usually have outlet obstruction. That's an indication. So if the path is open, these holes will close. But if path is closed because of a malignancy for which we are doing this procedure, then we are obliged to close these rents. Another thing happens is misdeployment. This is a cartoon which I have borrowed from this presentation. This is actually for gallbladder drainage, but the example is same. This green is a gallbladder. Now imagine this is a jejunum and this brown is a stomach. You can deploy the entire stent in the jejunum. Mishaps can occur this way or this way. You can apply everything in the stomach. If this happens, you've not burnt your way in, nothing, no worry. You can just lose the stent, but you actually don't have to send the patient for surgery. But this is a dangerous thing where you cannot retrieve it, or you have to puncture through it and place another stent in stent technique. Other deployments, mass deployments which can occur is called partial misdeployments, where half the stent is in the stomach and half is in the free space, which I told in the beginning. Now this stent has to be pulled out and this rent has to be closed with a clips. This is the most dangerous thing, where you have actually placed the distal flange in the jejunum, but the proximal flange is outside the stomach. And that's where, if you have realized it soon and your assembly is still inside, you can place the guide wire through it and place another stent through this. So a stent and stent technique can be done by which you waste another stent, but at least salvage the procedure and save the cost and the discomfort of the surgery. So misdeployments do occur because of use of guide wire in a freehand technique or learning curve of the operator. Gastric defects needs to be closed with an Ovesco clip. Leakages can happen, but if your stent is in a good position, these leak will often seal on their own. Hemoperitoneum, yes, it can occur. We had one experience in a patient who had a benign disease. I think we reported in a video endoscopy, video GI. This patient of a chronic pancreatitis with portal vein thrombosis and multiple collaterals and duodenal obstruction. Our surgeons were reluctant to operate because of so much collaterals in that area of GJ, of the duodenum, that they requested us to do this. And when we did this, we actually punctured one of the collaterals while doing this, and hemoperitoneum occurred. So we, fortunately, the stent was correctly positioned. So we took a pediatric scope through the GJ soon after, at the procedure, index procedure, after dilating this tract with the balloon. And we could see a varix in the duodenum which was bleeding. So we could inject a little bit of medicine into this sclerosing agent into that varix, ectopic varix. Stent occlusions are not a major problem. These stents stay open for a very long time. In fact, very recently, Takao has reported in one of his case reports, a stent was kept inside for 6 years in a benign disease patient, and that stent was still patent. So in the end, I would like to conclude by saying that EUS gastroenterostomy is an exciting endoscopy technique to create anastomosis between stomach and proximal small bowel. Water enhanced lamps should be used, not any other metal stent. And E-pass balloon adds to the safety. This is a double balloon. Technical issues and early learning curves are an issue, but I'm sure as we go forward, this would be taken care of and is safe with experts. And I think the first few cases should be done under supervision. Thank you very much for your kind attention.
Thank you, Sandeep. It was an excellent talk, as usual. Brilliant display of your skills. And the first question which has popped up is, as expected, the comparison between the US guided gastrostomy and the conventional stenting through the tumor. What's the problem in putting stent in stent? Will it not be more cost effective?
The enteral stent in stent technique.
The enteral stent, yes. Stent in stent, for the, just like common bile duct, when we do this stenting, if the stent gets blocked, we put in another stent within the stent. So can't we do it here as well? Can you crush the tissue?
Sure, it is. It's a very valid option, and I think it's the right way to address this issue. But we want to move away from the tumor, and if we can, because the second stent that we place, if it's uncovered, that also the tumor can keep invading. So either we use a fully covered stent or a partially covered stent.
I think
Sorry,
yeah, there's echo coming from somebody.
Okay.
Okay, Dr. Athar is
so that's the reason.
Replacing surgery as first choice for gastric jejunalostomy? Do you foresee this replacing?
I'm sorry, can you just repeat that? Do you foresee? Okay, I'm reading the question. Do you foresee replacing surgery as a first choice of? I think that time would tell, and as we become more experienced with this and safety gets added on, then I think surgeons would also like to use our skills.
And Kwang is asked how to avoid puncturing the colon instead of jejunum. Any particular technique that you use, other than all the things that you said?
Yes, so the complications usually occur when the procedure gets delayed. The longer it takes, the more chances of complications. So somebody should keep a watch on time, and there should be friends around you who can actually pick out what's going wrong. Because as we keep injecting contra, the small bowel and then the colon gets distended, and colon is very close to the stomach, and gastrocolostomy also has been described. So um, uh, I really don't know how to prevent it, except that doing as early as possible, and keep your eyes focused on one point, which is the next best loop. If you have a doubt, you can actually re-inject some contrast with a needle and re-identify it.
Sandeep, do you do this procedure under tube anesthesia or just conscious sedation?
So far, we have been doing under conscious sedation. We have not used endotracheal intubation for these patients.
That's
But
interesting.
I prefer to place my patients prone than supine. The reason is that the abdominal wall also is not compressed, so it brings the stomach very close to the jejunal loop. If it's supine, then sometimes if it's distended abdomen, it keeps going away. So personally, I feel the prone is a little better position for me.
So more like
That's my
ERCP position.
For like ERCP.
And how much methylene blue or the contrast do you inject in the in between the two tubes? 120 ml?
So we prepare a solution of in a container of about 250 cc of saline, contrast, and indigo carmine. The methylene blue we try to avoid because if it leaks into the peritoneum, it has some risk of it's a carcinogenic agent. That's why we don't avoid that. But indigo carmine is preferred, and a liberal amount of blue color should be there, not so that the color looks blue. Holy is there, so we see that color, and that coloring agent tells us that we are in the right position.
And do you empty the stomach before you go for endoscopic gastroenterostomy?
Oh yes. That's a very, very good point that you raised. So we do an endoscopy. We do an endoscopy 1 or 2 days before, because these patients have outlet obstruction. If they have food inside, it's best not to do all these procedures, because in case a mishap occurs, you can cause peritonitis. So best is to clean the stomach a few days before, or place a nasogastric tube to irrigate and clean it up. There should be no hurry in doing this. It can be 1 or 2 days, but it's worth the wait.
And do you leave the nasogastric tube inside the stomach, or you just clean the stomach and wait for 24 to 48 hours?
No, we leave the tube there. If he has a lot of liquid, solid food or a semi-solid food, and during this time, we ask the patient to keep drinking water. So his thirst is quenched, and this tube is open. So it will actually keep cleaning his bowel, his stomach, and use a widest bore nasogastric or Riles tube that we call.
Sad, you wanted to say something?
Yeah, Sandeep, excellent talk. Missed the first 5 minutes. I had to rush to deal with something in the hospital. So anyway, Sandeep, tell me, in your center, where is the place for enteral stenting now?
So we are doing currently a randomized control trial with other international colleagues of enteral stent versus GJ, and looking at the success rate and also the time to having any symptoms of occlusion. So personally, I feel that whatever has happened so far is retrospective experience only, and I feel that's my take. Hassan can speak on that.
I just wanted to see, the thing is that there is going to be a lot of difference in the expertise. So obviously that is very important. I mean, if you're used to doing enteral stents, and in my mind, listening to your talk, I feel that those patients who apparently seem to have relatively short expected or life expectancy, if you can place an enteral stent, it's very simple and easily done with almost no complications. And I think that's where we need to somehow decide about which patient, and of course difficulty, etc. But to be honest, in good hands, enteral stenting failure is also like Pretty rare, you
Yeah,
know it, but as much as
I
it's
totally agree
hardly
with
ever
you.
fair putting.
So it's not
Absolutely.
the failure in putting the stent. It's basically the blockage or the clogging of the stent that
No,
occurs at a later stage.
the point that this is what I'm saying. So most of your patients who come in with malignancy, now we have obviously those who are benign diseases is totally different ballgame. But malignant diseases obviously are pretty advanced by the time they have gastric outlet obstruction. And a lot of them would not survive beyond 6 months or 3 to 6 months, to be honest, some even less. So what I'm trying to say here is that your enteral stent life, generally speaking, quite often would, quite often covers up the life of the patient as well, if they have short span. So correct selection is what I'm saying. If you come up with certain criterias where you select the patient, I think then you have a place for both these systems and probably the best outcome for the patient. That's what I was thinking about.
Absolutely
Because I
correct,
personally
Sadia.
have no experience of, I personally have no experience of doing a jejunostomy. So that's coming from someone who has no experience.
No, yeah, you're absolutely right. I think the way to go forward is do an enteral stent in patients who have less than 1 month of survival. And that's what we have done in this trial. The inclusion criteria or exclusion criteria is that those who have very advanced disease and survival less than 1 month anticipated, we do enteral stent. We're not including them at all in this study. Those who have previous stents placed already are excluded out. And you're right that those who have ascites and liver metastasis, I think it's best to put an enteral stent and come out quickly, rather than if a mishap occurs, it will be a disaster.
Disaster.
Sandeep, do you suggest any dietary precaution in these patients after doing the procedure?
Very good question, Gyas. Yes, we tell them to have a low residue diet, like we tell them for also enteral stent, because the fibers can occlude. But this is much easier to clean up. In case something blocks the stent, we can easily take an endoscope and clean it up. Unlike an enteral stent, which can be blocked much beyond the C loop and where the scopes may not be easy to reach.
Mm-hmm. And any place of this procedure when the tumor is distal, is placed at a distal point, maybe at the DG junction or in the D4?
If the tumor is near D4, then I think it will be difficult to do. But again, we can look at the anatomy. If really you want to do it, then we can pass the nasojejunal tube and fill that area and see how close the loop comes to the stomach in a dry run before we actually plan the procedure.
Mustafa?
Thank you. Thanks, Sandeep. Excellent talk as always.
Thank you.
I'll just give a couple of comments based on my personal experience and to address Dr. Saad's question. I think sometimes what we're seeing here is that there are patients who are obviously advanced and they will not get surgery. Those patients, we will go with the jejunal stent. But there are patients who get neoadjuvant therapy who are being considered for pancreatic cancer surgery. And the surgeons and the oncologists will say, let's just start with a jejunal stent. And then over time, these patients may become non-surgical candidates and the stent starts occluding. And I found that in those patients, as a second step, rather than doing a stent through stent, switching makes a huge difference to their quality of life. And this is all anecdotal, retrospective sort of analysis. And I'll just sort of echo some of the points Sandeep very nicely pointed out that tenting is a big issue and spending too much time trying to do it is a big issue. The key thing is, I mean, I'd say to my fellow now is we're not going to overthink this. Find the right loop. And if we think that's the right loop, distend it as much as possible and deploy the stent. And balloon dilate. And actually, in our experience, we've started them on clear liquids the same day. And for the most part, let them advance to a full solid diet, and they tend to do quite well. So not even low residue. But all in all, I think it's a huge sort of advancement in terms of quality of life for patients compared to jejunal stents. And I think with your prospective study, it'd be very nice to see some prospective data on comparison with surgery. So those are my comments on this.
Sandeep, thank you so much for, as always, it's a pleasure to listen to you. And same thing is, as Mustafa said, I think I was going to highlight that point as well. When you start overthinking in any of these axios, when you're accessing other lumen, be it jejunum, be it any excluded stomach, more time you spend on that, the difficult it becomes. And once you have identified the area, you have put a fluid in there. And one thing is you go for it. And second is when you deploy the distal end, don't think at that point too much, because that's the time then you have to let the second flange go quicker than later. And other thing is like if you do the lumen, I don't know if you mentioned or not, I may have missed it. I was in and out of the office. You have to have a lumen. If you have a lumen straight sometimes, that makes it easy. And because then you go as deep as you can quickly after puncturing it, and it's easier to bring it back. So try to align the lumen in the long axis of the stent. And that makes it much easier. Then you don't run into a risk of going through the other wall. So that's one thing. Other thing about your study, so you said that you are comparing duodenal stent with the axios or surgical with endoscopic. So it's like 3 arms or 2 arms?
2 arm enteral stent, that is duodenal stent versus EOS guided gastroenterostomy.
Okay.
In a randomized way. But I'm
Yeah,
glad that
think
you raised the
that's
point. Sorry,
go ahead, Sandeep. Sorry about that.
I'm glad that Hassan, that you raised the point of a vertical limb, which I missed it out. That vertical limb adds safety to the entire procedure. So just talk your scope around and see which is the vertical limb. Beyond the DJ flexure in a normal anatomy, the vertical limb, that is the first part of the jejunum itself, is the right place to do that.
I was just going to add, I think it's important to have this study because we have made the assumption, and perhaps rightly, that duodenal is not as good as a GJ, but we don't have prospective data on this. So this one will hopefully, give us clear data to say one way or the other. And then I was just going to go back to one other point about D3, D4 lesions. Sometimes those are very tethered down towards the mesentery. And those patients actually tend to have a much harder time with duodenal stents in my experience. And if you can find a distal loop which you can safely sort of put an axial stent into, those patients tend to do better compared to even like a D2 or D1 obstruction. They may be more difficult for us to deploy the GJ, and it may take a while to figure things out and get the right limb and aligned. But I think once you get it done, then those patients do better. The big elephant in the room for places like Pakistan would be the cost of the stent. So I'm curious how in India you're doing this with the excessive cost relative to the overall cost of living in India and Pakistan.
That's a very valid point. Not everybody can afford an Axios in India, so it's only the affordable guys we are offering this to them, saying both the pluses and minuses of enteral stent and the GJ. If you tell them upfront and let them decide, then I think it adds value. Insurance is still not covering it, I think, and anyway, less than 10% of the people who come to us are insured. So it's going to be a different. I don't know how it's in US, Hassan. Are you doing US GJ insurance covers that?
It's just there is no separate code for that. Mustafa can help me with that, but the way we code is just like putting a axios or putting a stent, like a cyst gastrostomy. There is a code for that to put a stent, EUS guided stent into the cyst. So that's how we are coding. I don't know, Mustafa, you're coding something different way?
Yeah, we've met with that. So there are 2 components. There's the physician fee and then the hospital fee. So the physician fee part is not covered because there is no code, as Khalid said. So we will try and maximize it, maybe do a pseudocyst code and see if we can get that, because that's our highest EUS code for the physician fee. But we are working with our coders to sometimes submit surgical GJ codes, and based on the insurance company, it may get approved, and then you get a higher physician fee. The hospital side, which obviously is a much bigger chunk of the cost, usually is covered by the cost of hospitalization by the insurance. It's usually in the order of like days of hospitalization. So that part pretty much covers it. I think we're doing it, you know, with general anesthesia, all these other sort of high cost environments, that side gets covered in the US.
And we kind of have similar issue here in UK because things are block contracts. So you get a block contract for doing 100 procedure that doesn't really take into account what sort of procedure you're doing. But I think in some ways I see that people or patients in Pakistan are being disadvantaged because an accessory or LAMS, which is rapidly taken over many of these advanced therapeutic procedures, if it is not available in some ways, I think it's a disadvantage to our patients. Now, if I may ask Sandeep a couple of technical questions, I think one of them is, what's your preference, Sandeep? Is it a freehand technique or is it kind of wire-guided technique, especially if you haven't got that double balloon catheter available? Again, we have limited experience, but I think initially when we try to do it with a wire-guided approach, we really struggle with it. And when you're trying to deploy the stent, you get a feel as if the bowel is trying to move away from you. Whereas it was much more comfortable with a freehand technique when the bowel was adequately distended with this contrast-filled solution. And then the second question that I have for you is, I don't know whether you've used or experienced using these, you know, LAMS or Axios have made available these new stents which have a saddle length of about 1.5 centimeter. And about the bowel movement post deployment, would there be any additional of using those stents with 1.5 centimeter saddle or not?
So the first question first, that is the freehand technique versus the double balloon technique. The double balloon is still not commercially available. So we have an access to it because of the part of the study which Takao has shared with us. And that makes things easier. Freehand, I've seen some people do it very elegantly. I've seen Manalo from Spain doing it very nicely. Moin Kasab do it, and they're very easy. It looks as if tomorrow you can start it off. But also I've seen some people struggling or doing easily, but it ends at a mishap. So that's what I felt, and I have not done it without an EPAS so far, except for the patient that I described, which had a fixed jejunum because of the tumor or the surgery, where things become much easier, where you can actually pass a guide wire also because the loop will not run away. So in a patient who has a free jejunum, if we can fill it up and hold it there with the balloon and distend as much as we can, it's very capacious. Although sometimes in one case, we had a problem of the balloon, in spite of being filled and anchoring the lumen, the contrast still went beside it. And then there was a little struggle and delay. And then the contrast filled distal part. And that's where when our the loop or the tubing seen through the third part of duodenum helped us to identify which limb we were looking at. So that thing is important. So personally, I feel that if you can get a hand on this kind of a device, which is double balloon, there's an Indian doctor who has recently made one similar kind of device with his own hands and his technicians together that looks equally good and elegant. And that's much more stiffer and doesn't require an overtube. And let's see how it moves forward. Your second question of using the other stents, the LAMS compared to Axios, this can be done. And the hot spaxes, one of my friend from Thailand, Pradam Chat, has done some of the cases, including Anthony Teo from Hong Kong, who have used spaxes stent, which is 16 millimeters the maximum diameter. The hot spaxes can be placed in a similar way using the double balloon technique. So most of the people who are I am aware of in the Asian country, the East Asian part, are using a double balloon technique. And Europeans and Americans are using a freehand technique, using a nasojejunal tube or a nasocystic tube and filling very quickly, vigorously using a pump. So that prevents, so it has to be a very quick move. That small window of opportunity which is available should just be grabbed. Also, you need to paralyze the small bowel using a Buscogast or a glucagon to prevent the fluid to moving distally.
And Vasab, you want to say something?
Yeah, a very quick question in interest of time. Thank you very much, Sandeep. Enjoyed your talk.
Thank you.
For a Pakistani perspective, if you don't have axios and you use the regular, stent.
Sorry, I can't hear you. Can you, sorry, I could not hear the question. Can you please repeat it? Yes.
Okay, can you hear me now? Can you hear me?
Yes.
Yeah.
Yes, I can.
Okay, so if you don't have axios available, like in our Pakistani situation, cost or everything, and if you use the regular stent, it is easy to use these stents for pseudocysts because it's kind of attached to the stomach. But for a duodenal stent, isn't that a chance that the duodenal stent, because the duodenum is moving away, you could lose the distal end, although you can anchor the gastric end of the stent with either with Ovesco or whatever clips you can use.
Yeah, that's a very good point. So we should use only stents which have a lumen opposing capabilities, whether hot or cold variety. But the biflank stent which are not fixed have a chance of migration on either side, and that can be troublesome. So we don't use Nagi stent, which is very commonly used in India for this purpose.
Sandeep, how long
Yes,
do you
Sir.
keep the patients in the how long do you keep the patients in the hospital after the procedure?
So we keep at least for 48 to 72 hours, and we just keep screening them every day to see the stent expansion. I don't believe in expanding the stent with a balloon, and let the stent expand, which also helps in kind of fixing up with the bowel. So generally by 40 to 72 hours, we let them go. We start making them orally, take orally next day, and with clear liquids, and 48 hours later, or we make them do a contrast study to see if it is going distally, then they can take little thick liquid soups and other things. But we tell them not to take fibers in the diet, which may cause some kind of a blockage.
Sandeep, one other question: how you choose the patient between endoscopic and surgical, and how do you convince your surgical colleagues? And what are the best cases for EUS guided, and what are the best cases for surgery? How do you decide that?
Sure. Good question, Hassan. So any patient who doesn't have ascites, who looks to be operable, I think we send them to surgeons, and once surgeons look into it and they feel it is, are they going for diagnostic laparoscopy and they find inoperability, at least they convert into a GJ at least. So that's how they take on forward. It's the other way around. Most of the GJs that we got is from surgeons, which they did not want to operate. And so it's a give and take which happens. Although so we realize that which are the ones if they come to us and we know that they're not going to operate, for example, ascites, metastasis, disease, and previous stent already there inside, the cost of surgical GJ sometimes can be a little more or almost as much as US GJ.
So what I'm trying to get, the point I wanted to stress is, first of all, these type of cases are already short in number. And on top of that, for EUS guided or endoscopic guided, it's even further, you have to be selective and very few cases. So maybe this is not for, it's not going to be a procedure like cyst gastrostomy that you get so many of those. So number of these is going to be really small. It's at times it's a very tricky procedure. It may look easy when some expert is doing it, but it really is not. And you have to have a good experience. So it's not one of those cases where you can see few of those and start doing it. And you may not get, you may get one every 6 months, something like that, or one every 4 months. So it's not going to be very common procedure. That's what I'm trying to get.
With big cities like Karachi, Lahore, Rawalpindi, I think the patients are going to be many who may be candidate of EUS guided gastrostomy. It's just the cost which is prohibitive, because not many people are going to afford this much costly stent. Although they're going to be patients who will love to have this minimal invasive kind of intervention. But then I agree with you that learning curve and expertise requires the numbers, which are clearly going to lack in this case. If there are no more questions, it remains for me to thank Sandeep and all the participants, all the co-panelists who have been there. Saad wants to say something. Saad?
Yeah, I just wanted to thank Sandeep. That's it, and wish him Holi, and to all your family, and especially because we've only given you a very short notice for this talk. So, Riaz, you wind it up, but I just especially wanted to thank him. Okay.
That is perfectly fine. That we all together, and we have been wishing great Holi to Sandeep and his family when we started the session. You joined late. Anyway, thank you very much, and wish you all the best and safety from COVID, and wish you a very good Sunday evening. Take care. Khuda Hafiz.
Thank you,
Bye bye.
Thank you, guys. Thank you, Saad.
Thank you.
Bye,
Bye,
Hassan.
Sandeep.
Bye-bye. Thank you.